I am not bound to win, but I am bound to be true. I am not bound to succeed, but I am bound to live up to what light I have. Abraham Lincoln. This night, a welcome shift in the tapestry of my medical career promised experience in a new ER and some coins to my paltry bank account. The world of medicine offered its peculiar brand of opportunity as healthcare professionals were in constant demand. Locum coverage for rural hospitals is a scarce commodity rewarded by many staffing companies. As the sole physician on duty in the emergency department, the typically bustling scene conspicuously absent tonight, I enjoyed the unexpected lull. The prospect of paid sleep, a foreign concept to the perpetually overworked, was tantalizing. I retreated to the back office, a makeshift sanctuary tucked away from the chaos of the ER. Despite the availability of empty patient rooms, the nurses' tales of ghostly hauntings, rooted in the tragic history of the local tribe, deterred me from such a venture. The weight of my eyelids pulled me into a dreamlike state, a fleeting escape from the demands of my profession. My slumber was abruptly interrupted by the familiar chime of the ambulance dispatch, a sound that had come to evoke a visceral response, a mild form of PTSD that persists yet some 20 years later. The hospital, a remote outpost in a rural wilderness, was plagued by unreliable radio signals. The EMS report, garbled and difficult to decipher, indicated a 15-year-old male with severe arm burns, expected to arrive within 20 minutes. A wave of confusion washed over me as the spindles of sleep faded. My dream, a fleeting respite, was shattered, replaced by a growing sense of unease. How could a teenager sustain such severe burns on a sub-zero early morning? The world should have been wrapped in slumber. I asked the charge nurse to contact EMS and clarify what they were bringing. The second radio call was a 65-year-old male with facial burns, the extent unknown. Reality tipped the equation to the dark side. Depending on the mechanism and severity, facial burns can imply many things. The most dreaded are burns affecting the airway, which can result in rapid and massive swelling. This makes gaining control of the airway challenging, and the familiar act of placing a breathing tube, endotracheal tube or ET tube, becomes exponentially more difficult or impossible. Factor in that I was it, the whole show. There were no other physicians or specialists to help me. No cool, technologically advanced tools, or a spare set of experienced hands to assist if I failed. I would have killed for the fiber optics of a GlideScope device to help intubate this type of patient. I prepared mentally for his arrival. This life hung in the balance, a delicate thread soon to be held by my trembling hands. "Call the burn center," I barked, "and tell them to dispatch immediately. I'll give them a report after I intubate him." The journey to the burn center, nearly 180 miles by air, was a race against time. Tonight, I was on the other side of the helicopter's rotors praying for the flight crew's expedient arrival. A chilling narrative of survival unfolded piece by piece this night. The patient, out with friends, had consumed a significant amount of alcohol and was driving home when a freak accident caused a fire to erupt from his car. Fueled by a desperate desire to retrieve his beloved red coat, he leaned into the car, the flames engulfing him. His fleece jacket, a synthetic nightmare, ignited, melting into his flesh. Witnessing the blaze, a passing motorist called 911 and rushed to his aid, pushing him to the ground and smothering the flames with their coat. The ambulance crew, arriving on the scene surprisingly fast, quickly transported the patient to us, his torso still smoldering. The ER doors slid open, a blast of frigid winter air invading the emergency department. Instead of the expected 15-year-old or 65-year-old, I was confronted with a patient eerily similar to myself. He stared at me with wide eyes, his words a stark contrast to the severity of his condition. "What the fuck are you looking at?" The look on my face must have spoken volumes. The patient, a chilling doppelganger, mirrored my height, build, hair, and eye color. The resemblance was unsettling, a haunting reminder of the fragility of life. As I began my assessment, the room, a tense tableau of awe and horror, fell silent. Gasps echoed through the air as the gravity of the situation dawned. The sequence of actions was clear, A, B, C, D, E. The airway, a ticking time bomb, was the immediate priority. His raspy voice, a stark testament to the damage, demanded urgent action. His tongue and airway, swollen and charred, were a stark reminder of the inferno he had survived. Time, our relentless enemy, was rapidly slipping away. I instructed the nurse to attach monitor leads and an oxygen sensor, urgency lacing my voice. 2 large IVs were essential, a lifeline in the face of impending disaster. Frustration, a bitter pill to swallow, washed over me, as I noticed the sluggish pace of the room. "Where?" the nurses queried, their confusion starkly contrasting the situation's urgency. "Anywhere," I barked, my voice a mix of frustration and desperation. "His arm, hand, foot. Just get the IV in." The oxygen sensor, a simple task in most cases, presented a unique challenge. His fingertips, a casualty of the fire, were gone, leaving only a few toes. The realization that he was shoeless compounded the problem on this frigid morning. "Fix me or I'm coming for you later, you piece of shit," he spat, his raspy words a stark defiance in the face of pain. How he could muster the energy for such a threat was a testament to his will to survive. Portions of his eyelids were burned away, his lips charred and swollen, his left ear a crumbled ruin. From the waist up he was a charred husk, devoid of clothing, skin, and hair. Everything was gone. Several skilled nurses, whose expertise was tested by the unforgiving nature of the burns, could not secure IV access. The patient, chilled to the bone and drenched in the remnants of the fire, presented a formidable challenge. The typical access sites, ravaged by the flames, were unusable. An intraosseous line was the only viable option. This device allows a needle to be inserted into bone to administer fluids and medications, but it was unfortunately unavailable at the facility. The nurses, their persistence commendable, searched for a suitable site on his feet, but to no avail. The groin, the last remaining option, was a daunting prospect given the degree of burns. Also, our patient, distressed, intoxicated, and combative, made the procedure even more challenging. Intubation without the aid of chemical sedation was a risk I was unwilling to take. I instructed the nurse to administer an IM injection of a sedative, then swiftly inserted a femoral triple-lumen catheter into his groin. Then additional sedative and paralytic drugs were administered immediately, followed by the critical task of securing his airway. The burns to his mouth and tongue, combined with the effects of smoke inhalation, posed a severe threat. If I failed to intervene, the patient would perish before our eyes. With a Herculean effort, the endotracheal tube was inserted and secured. Oxygen saturation returned to normal, and IV fluids were administered rapidly. The extensive burns required a significant volume of fluids, a calculation made expertly by the timely intervention of an ex-military pharmacist on duty that night. The emergency department, a sanctuary in theory, was often a microcosm of the community it served. In smaller towns, the lines between patient and bystander blurred, a familiarity that could hinder and help. The trauma resuscitation room, designed for privacy and efficiency, was overrun by a swarm of family members. The doors pushed open with a force that defied the hinge's weight, spilling a wave of humanity into the already crowded space. Slipping away to speak with the burn center physician was a challenge. I was immediately cornered in a dimly lit corner by an intoxicated family member, his demands hampering my tasks. I reassured him of our heroic efforts, emphasizing the severity of the burns, equal to the worst I had witnessed during a rotation at a burn center years before. His response, a fist aimed at my face, underscored the raw emotion and desperation that fueled his demands. His agitation was interrupted as the flight crew pushed into the ER, taking command of our patient. Their efficient intervention, a brief yet critical interlude in the chaos of the emergency department, provided a sense of relief. The team quickly transferred the patient onto the flight cot and whisked him to the helipad. With a stroke of luck, this crew also flew in a Sikorsky capable of traveling 287 km/h, faster with tonight's robust tailwind. A debriefing, a necessary ritual in the aftermath of such a traumatic event, was conducted, and the case details were dissected and analyzed. Many staff members personally acquainted with the patient were reluctant to discuss their feelings. As an outsider working in a remote tribal hospital, I observed the scene from a distance, a silent witness to the raw emotions that lay beneath the surface. Overall, the case had been managed appropriately, a testament to the team's efficiency and skill. A review of the trauma flow sheet revealed a remarkably brief stay in our ER that night, a blessing added to the favorable winds that had carried the flight crew to our remote outpost. The initial shock and disbelief, a fleeting moment, had given way to a determined response. The staff, with their extensive experience and teamwork, seamlessly transitioned into action, their movements a synchronized dance of skill and compassion. The initial stabilization and resuscitation phase had been executed flawlessly, a testament to their unwavering dedication. Reflecting on the case, it was evident that our actions had been swift and decisive. The patient's brief stay in the emergency department, a testament to our efficiency, highlighted the gravity of his injuries. Despite the novelty of our collaboration, we functioned as a cohesive unit, rising to the challenge with unwavering determination. The patient, tragically, had succumbed to his injuries 2 days later. Third-degree burns, a merciless assailant, carried a devastating prognosis. The patient's fate was sealed the moment he reached the burning car, a fatal, intoxication-clouded decision driven by a misplaced desire for material possession. The adrenaline rush, a fleeting surge of energy, had faded, leaving behind an emotional void. The realization that despite our best efforts, the outcome was predetermined was a sobering reminder of the limitations of medical intervention. The practice of medicine, a relentless teacher, humbled us all,